Okay, let's talk about this cool case of endophthalmitis and orbital cellulitis. So this was a 44-year-old male who presented to the emergency department with worsening left eye pain, endorsing additionally discharge, vision changes, swelling, and redness. He's never seen an ophthalmologist. He has no eye history. He doesn't wear contact or corrective lenses. Denies any recent injury. He does have a sensation of a foreign body a few days prior, but no explanation for it. He has no fever, no headache, or other symptoms, and he denies any past medical or surgical history. On exam, his vitals are okay. His right eye is essentially normal. There's a little bit of swelling towards midline, but his eye is okay. The left eye is very abnormal. He has no vision or light perception. The upper and lower lids are swollen and red. The left pupil has poorly visualized due to the density of the exudates that you have to pry apart to open the orbits or open the lid. And the left eye is proptotic. On the right here, we don't see exactly our patient, but just to describe this, we definitely see swelling of the upper and lower lid. We see somebody holding it apart because the edema is so significant. We see significant conjunctival injection and chemosis of the sclera and conjunctiva. We see a dilated pupil and otherwise, and there's a little bit of gunk here in the middle. So there's some room here at the middle, okay? Some exudate. So let's talk about periorbital cellulitis, okay? This is also called preseptal cellulitis, and I think of it as extraorbital cellulitis. Essentially, this is the type of cellulitis around the eye that doesn't involve the eye or the orbit. So preseptal, okay? And it's an infection located in tissues anterior to the orbital septum, which is illustrated here on the right, okay? So this blue line is essentially this ligamentous structure, thick structure, which sort of keeps the external eye from invading the internal eye in situations like this. The orbital septum is fibrous, sorry, not ligamentous, and protective barrier. Thus, periorbital cellulitis does not generally progress into orbital cellulitis. And an infection results from local trauma in adults. In kids, they have bacteremia. So either one of those can cause it. And then on the illustration here, just to sort of review this again, you see the orbital septum here, and then here's some of the symptoms of periorbital cellulitis, right? The upper and lower lids are swollen, the eye might be a little bit red, but extraocular motion and all the other things you think of with orbital cellulitis should not be present because this is an extraorbital or preseptal form of infection. Orbital cellulitis is a progression of this sort of disease spectrum into the orbit, okay? So now you have a soft tissue infection posterior to the septum, which again is illustrated here. And it arises from the sinuses, typically, especially the ethmoid sinus, more common in children. And then these patients are a little bit sicker, right? Their eyelids are swollen, red. They have some proptosis, meaning the eye is being pushed out of the orbit from the swelling. They have chemosis. It hurts to look around because of the swelling of the extraocular muscles. And subsequently, they can have reduced mobility, okay? They typically do not have systemic symptoms unless there's something else going on. And here are some of those things. So the fat and extraocular muscles are very edematous here. They have pain with extraorbital movement, especially upward gaze, ophthalmoplegia, visual impairment, which is really manifesting as diplopia, and proptosis. And then endophthalmitis is sort of the end of the spectrum of eye infections. Okay, this is the most severe form. It involves inside the eye, the vitreous cavity. It can be either exogenous from surgery or trauma or something external to the eye, and it can be endogenous, meaning the organisms reach the eye via the bloodstream. It involves progressive vitritis, a heavy infiltration of the orbit proper with white blood cells and neutrophils. These patients have even worse symptoms. They have vision loss, they have a hypopyon in the anterior chamber, their eye hurts, they have a headache. And then it can sort of progress to panophthalmitis, where the whole eye is involved, corneal infiltration, perforation, and then orbital cellulitis is also included in that. This is the worst form of eye infection and frequently results in visual loss or even permanent visual impairment. The symptoms of endophthalmitis include headache, eye pain, photophobia, vision loss, and discharge. You can see conjunctival injection, hypopyon, corneal edema, eyelid swelling, chemosis, and a relative afferent pupillary defect. In this image on the right here, you see significant chemosis of the conjunctiva. You see a hypopyon here, right? So this is pus and white blood cells sitting in the anterior chamber. This is a very sick eye. Evaluation includes just sort of your basic eye exam, right? So a slit lamp, You want to measure intraocular pressure and use ocular ultrasound if you've confidently excluded a globe rupture. You also need to get labs just to sort of get a sense of how sick this person is. And then most importantly, gram stain and culture of the eye itself to help guide decision making in terms of antibiotics. Imaging, you can do CT with contrast, sort of in the ED, that's the best test to get a sense of what's going on inside the orbit. Um, Treatment for periorbital cellulitis, again, this is the preseptal version. These patients do well with oral antibiotics targeting, your common gram-positive organisms that are skin flora, staph and strep primarily. Orbital cellulitis is a sicker patient. The infection is now in the orbit proper. These patients get admitted to the hospital. They get IV antibiotics. They get seen by ophthalmology and infectious disease. Sometimes the fluid collections require drainage, but not always. And then endophthalmitis, again, the most invasive form of this infectious spectrum. These patients also need fortified eye drops. Sometimes they need antibiotics administered into the orbit proper, intravitreal, and possibly a vitrectomy. Again, these patients can be very sick. In the case of our patient, they were diagnosed with both orbital cellulitis and endophthalmitis. The CT showed proptosis, distended anterior chamber, mild posterior displacement will infiltrates in the preseptal and periorbital soft tissues. This patient was admitted to the hospital on both ceftriaxone and vancomycin, as well as topical antibiotic eye drops. The patient did not really improve after 10 days of this treatment and had an elective surgical enucleation of the left eye to help control the infection. So 3 key points on endophthalmitis and orbital cellulitis. The clinical signs and symptoms of orbital cellulitis include eyelid swelling, redness, proptosis, chemosis, pain with eye movement, and ophthalmoplegia. Treatment involves the use of broad spectrum IV antibiotics and close collaboration with ophthalmology. And endophthalmitis is the more severe form that involves an intraocular component, not just the orbit, caused by infection of the vitreous cavity and can progress to orbital cellulitis or extend outside of the orbit or outside of the eye into the orbit.